Chapter 31, Section 15. Human Immunodeficiency Virus, and also known as HIV and AIDS. AIDS is the acronym for Acquired Immunodeficiency Syndrome. This was recognized back in 1981. This is a distinct disease. Problem was, AIDS is not a disease, a disease where here are the 10 symptoms. Look for these 10 symptoms. This is the disease. It's more of, as they say, a syndrome. People who have AIDS are going to have any of these 20, and I'm just picking that number off the top of my head, 20 symptoms. They can have all 20, or they can just have 3, or any number in between. And that was the problem they had at first. It was this outbreak they were seeing in predominantly the gay male populations. So they thought, if you go back and you read and you hear people talk, yes, in mid-early 80s, they thought this was just the gay disease. Something about their lifestyle was causing this. And the problem was that it was outbreaks of this in multiple cities across the U.S., multiple cities worldwide. And no two of the people with this had exactly the same symptoms. So it was throwing monkeys in the wrench. So about mid-80s, there was this big push to find out what's going on. How? Epidemiologists were trying to track, and I'm not trying to be disparaging or anything here, but in some of the populations, San Francisco, New York, Summer of Love, the 60s and of the late 60s, was still alive and well in the gay populations of those cities, also in Paris and London. So trying to track partners was a bit of an issue, and then also the stigma that it was the gay disease. Some of the things, the problem is AIDS doesn't kill you. AIDS allows weird things to kill you. Feline leukemia virus, fungal infections, weird things like that. So they were having problems. So they were pushing, trying to find the virus. To have a disease, you got to have a causative agent. Once you have a causative agent, then you can start to figure out how the disease is spread, how it makes people sick, or how it immunocompromises these individuals so they become sick. About 1 million people here in the US right now may be infected. Worldwide, about 80 million, which, we stop and think there's 7 billion people. That's not a lot compared to the overall global population, but that's still a pretty big number. Over the past, 3.5 decades, 4 decades, about 34 million people have died. This has hit certain countries, certain continents, Africa, Haiti, certain places like that, has hit them the hardest. What we do know, once they figured out, Gallo, Dr. Gallo is the guy's name, the one who's chiefly given the accolades of identifying the AIDS virus, the HIV, human immunodeficiency virus. There was a competing U.S. and French research groups. Gallo was the U.S. guy who was the first to put it out. I've identified it. I've got it. Some argument back and forth who did it first, Gallo or I can't remember the lead investigator in French, but we give it to Gallo. He's the one in the textbooks. Since then, over the past few decades, what we have found out, what we have studied and figured out, is how it works. HIV, the virus, it's true, tropic target. Remember when I say tropic when it comes to viruses, this means this is the true host. This is where the majority of everything can and will occur. While it can still infect epithelial cells, that's just a transient infection. It truly wants to be in CD4 T cells. Why is that a problem? Well, guess which cells are responsible for regulating your immune system, to letting your immune system, specifically your CD8 cytotoxic T cells, the cells that are responsible for going and finding and telling cells you need to die, you're viral infected. CD4 helper T cells. CD4 helper T cells activate B cells, so you make antibodies, but then they also activate the T cell, the CD8 T cells, to go out, find, and kill the viral infected cells. So basically, this is the big cog, the central cog in your immune system reaction to viruses. That's where it's evolved to hide. It's also why the difference between you, healthy individual listening to me blather on, and somebody who has HIV, or I'm sorry, who has AIDS, is their CD4 numbers. You have nice high CD4 numbers. I forget the exact number of CD4 cells, T cells, but once it dips below a certain level, you are technically AIDS. There's no recovery. HIV can infect other cells, okay? It's not going to CD4 directly. CD4 are hiding in lymph nodes and things like that. Skin-to-skin contact during sex, whether it's penis to vagina, penis to anus, whatever. Spread, it's going to infect the cells of the mucous membrane. It's going to affect the underlying epithelial cells. It's going to infect macrophages. What are macrophages going to do once they find something not you? They go to the nearest lymph node. Hey, guess what's in the nearest lymph node? CD4 cells. What we do know. HIV, it's an envelope virus, has these proteins in the envelope that recognize, interact with CCR5. Spike proteins, GP120, GP140, interact with CCR5, and a co-receptor, CD4. CD4, that's why we named these T cells CD4. CD8 on the CD8 cytotoxic T cells. See the pattern? Once they interact, they will pull in. And here's this weird thing about membranes. You take two membranes and you push them closer and closer together. What's going to happen? They extrude the water between them, and you cannot have two hydrophilic heads touching. They get closer and closer, water gets extruded, boom. They fuse, which is what they're showing here. So now it becomes one continuous membrane. The nucleocapsid is now released in the cytoplasm, which will then release the RNA genome. Remember, these guys are RNA viruses that have reverse transcriptase, RNA-dependent DNA polymerase, something that does not show up in us. It's not even in our genome. And then it goes latent. Once the RNA-dependent DNA polymerase makes a DNA copy, that DNA then inserts HIV's version of a prophage into our chromosome, and then it just hides. Weeks, months, years, whatever. Slowly over time, yes, a couple of viruses will bleb out, spread, but viral load drops, bottoms out. Doesn't completely go away, but it now becomes below levels of detection for most assays, unless they're doing DNA assays. Some point in time, some trigger will cause them to pop out, the viral DNA to pop out of the chromosome, start making copies, start making viruses. Viral load goes up, goes back down, up and down as it spreads to new CD4 cells until something happens and the CD4 cells that were already infected start to die off, virus comes out, viral load goes up, CD4 levels plummet, they're now AIDS. Within the first few weeks of infection, flu-like symptoms. Somebody thinks they got the flu, goes away, but then they get some lymph node adenopathy. Lymphadenopathy is what they call it. The lymph nodes, groin, whatever, start to swell up, a little tender. Nothing like, oh my God, oh my God, oh my God, I'm in pain, I need to go away. Then it goes subclinical, boom. Or the numbers just drop, go away. Don't know. When we look at these different times after exposure, look at this, 1 year, 2, 3, 4, 5. In the 80s, into the early 90s, before we really got treatments, what we noticed was lifespan, 5 to 7 years. So this stretched out, so 7 years, could be as short as 5 years, 3 years for some people, depending upon what their health was like, what they're being exposed to. But notice, over the years, their CD4 levels drop. 200, I believe, is the mark. Below 200, you're AIDS. Up here, normal range, still have a healthy immune system. Still look healthy, still are healthy. This range, you kind of look healthy still, but you're getting sick and you just can't get rid of it for some reason. Down here, you're catching anything and everything. And yeah, you're looking sick. You have weird sores, weird things happening that, well, humans shouldn't. We do know that there are a couple of versions of HIV out there. How is it there are a couple of versions? Well, Africa, people in Africa spreading around their own amongst themselves. People in Europe spreading around. People in the US, people in Southeast Asia. You know, yes, there's people going back and forth between them, catching it, spreading it. But, I mean, think about like with this COVID thing that's been going around. The alpha, the beta, the gamma, whatever. They're coming from different places around the world and spreading because they passed it around amongst their own little population and then it gets out. Well, same with AIDS. HIV-1's the more virulent, HIV-2 less virulent, milder. You still get an AIDS disease, you still get AIDS, it's just longer, prolonged time to get there. What actually kills AIDS patients is not HIV. It's getting diseases that no human should. Literally, they will die because they get fungal growth on their brain. Different types of fungi. Yeast will be growing and colonizing their meninges. Feline leukemia virus. Pneumocystis jirovecii. They get a weird killer case of pneumonia that they shouldn't. Their immune system is shot. I mean, they're still making macrophages and neutrophils, but there's only so much they can do. You need to have the B cells making antibodies, and you need to have the T cells coming through and killing things that are infected. They're not there. Candida albicans. Basically, they get an overgrowth of yeast. This is one of the things with AIDS patients. Yes, the same Candida albicans that causes yeast infections in women, causes yeast infections in genitals of males, but you'll get this overall overgrowth, not only in the mouth, oral, but in the sinuses of AIDS patients of the same Candida albicans. What it is doing, it's growing, it's overgrowing, and they get this frothy, bread smelling discharge. I mean, they're just foaming at the mouth. It's coming out their nose. And it will actually, I forget the gland, the passage from the sinuses to the eye socket. You'll even get the overgrowth coming from the sinuses into the eyes. And then you get this discharge coming from the eyes. Cryptococcus neoformans. This is another. This gets down into the lungs. They're going to have histoplasma, a fungal growth that's growing mouth, sinuses, genitals, anywhere else. Pneumocystis girovicea, which is down in the lungs. Cryptosporidium, which they're ingesting, it's now overgrowing the gastrointestinal system. Toxoplasma gondii, overgrowing, getting into their tissues. Here they're showing it in heart muscle. Yeah, Toxoplasma gondii, which should be in the gastrointestinal tract, somehow was able to penetrate tissues, get into the underlying capillary beds, and then carried throughout the body. The moment it broke through the mucous membrane, you, as a healthy individual, your immune system would have wiped it out. I'm talking nuclear option, go for broke. AIDS patients don't have that. Now they're getting their heart colonized by what should be a gastrointestinal parasite. There's going to be some key signs. Remember, the difference between symptoms and signs. Symptoms are things that the patient tells you about. I don't feel well. I'm achy. I hurt. Signs are things you can measure, things you can visually see. Sign, rash, pustule, started the face, moved to the trunk. Sign. Fever. Here, I measured the fever. 100, it's 39 degrees Celsius. 102.5 degrees Fahrenheit. Sign. Elevated heart rate. Sign. Another sign you're going to see is what is referred to as Capocity Sarcoma. It's a type of cancer. It's growth that's normally associated with AIDS. This is going to be cancers of the blood vessels. Remember, your blood vessels are actually a type of epithelial cells that are forming the tube. They get damaged. They need to be replaced. They have mitotic events, just not as often as other cells. Well, if they have mitosis, they can have a chance of something being screwed up. You end up with this cancerous growth, known as the Kaposi sarcoma. Kaposi sarcoma, more often than not, is caused by people who have HIV infection and human herpes virus 8, HHV8. HHV8 by itself doesn't cause this. You have to have these two going on at the same time. Only then will you see Kaposi sarcoma. Normal conditions, you get exposed, human herpes HHV8. Asymptomatic, self-limiting. Somebody who's already got HIV and they're showing depleted immune responses, well, they start to see this. And for whatever reason, every time I see pictures of Kaposi sarcoma, it's always down on the lower leg, ankle, foot. Don't know why. Don't know if that's just the best pictures or if that's the only place Kaposi sarcoma you will see. But all I know is those are the only pictures I've ever seen in textbooks, in literature. So, but this you see here, remember I always tell you, if you see black tissue like this, and I'm not talking African American or anything like that, I'm talking black in what should be white. For people who are of African descent, yes, your tissues may look black, the epidermis, but you look below them, it should be nice and pink. Those are, if that's turning black, that means it's going necrotic. So, necrotic here, on its way, because blood's not flowing through, because this is now a tumor, tumorous tissue, cancerous tissue. Blood's flowing around, just not in here. So these cells, the inflammation, as the cells around this are dying and the body's trying to repair, trying to wall off. HIV diagnosis. There are many ways that we now have for HIV diagnosis. Some are faster than others. Some are using old school methods of antibody interaction with HIV proteins. See if the virus is in your blood, or they're testing for the presence of antibodies to HIV virus in you. Test for the virus to be there, test for antibodies to be there. So here in the US, North America specifically, we designate people HIV positive, HIV negative. When somebody's HIV positive, what that means is they are positive for presence of antibodies to HIV. To have antibodies, that means you have to have been exposed, have to have had an infection. Does that mean you have HIV and virus in you right now? Don't know. But if you've been exposed, there's a pretty good chance. If you're HIV negative, you've never been exposed, so there's no way your B cells would even know it exists, so why would you have antibodies to it? Over in Europe, they are, I forget which clinical phase they're in right now. They may be trying to get it out there. Vaccine, HIV vaccine. Everybody will now be what we consider HIV positive. They will have antibodies. The antibodies, depending upon which vaccine they have, it'll be just antibodies. Boom, that's it. They will give a protection, some protection against you getting infected. If you get exposed, it'll offer some protection against getting infected. There are other vaccines that are giving a chemically treated virus. It has been damaged to the point, mutated to the point where it cannot infect, do its replication and spread. So it can, quote unquote, mimic the infection up to a certain point, which means not only will your B cells learn it to make antibodies, but your T cells will learn it so they can be constantly on the hunt for virus-infected cells to go and kill. What's that going to do to us here? Well, basically everyone that comes over from Europe is going to be testing HIV positive, which is going to say everyone means they're now going to have to turn around and start doing the rapid test or the DNA tests, RT-PCR, looking for HIV RNA in your blood. Right now, we're stuck where HIV positive, yay, nay, that's where we are, because we want to limit the spread of the disease by limiting, exposure events. Europe, they're saying, hey, look, you're getting exposed because you're having sex, you're doing stuff. So we're going to come up with a vaccine so that if you win, not if, but when you get exposed, pretty good chance you won't get sick. This is all the stuff I've already talked about, so I'm not going to go into that. Treatment. As I mentioned before, a few slides ago, HIV is an RNA virus. in us, once it gets released into our cells, reverse transcriptase, the RNA-dependent DNA polymerase, something that does not show up in our bodies naturally. We don't even have the gene for it. Takes the RNA copy, turns it into a DNA copy. Our machinery, our cell machinery, can recognize and do stuff with DNA. Well, if you come up with an inhibitor for that reverse transcriptase, well, in our cells, any RNA, viral or our cell's RNA, has a very short shelf life. It will get damaged, it will get turned over, it will be erased, as long as you can keep the reverse transcriptase from doing anything with it. Then you can also come in with, nucleoside, other reverse transcriptase inhibitors, something that's going to clog it up, something's going to denature it, interfere with its shape. Protease inhibitors, there are certain viral proteases, help form the capsid, help form the GP proteins that are embedded in the envelope. These are protease inhibitors that are somewhat similar, but not really, to our own proteases. Good target. Fusion inhibitors keep things from, the envelope from fusing with cytoplasmic membrane. You take all of this and you make a cocktail of it. This is what is called highly active antiretroviral therapy, HAART, H-A-A-R-T. It's why here in the States, instead of a 5 to 7 year life expectancy, we have people that are now measuring life expectancy in decades. 1, 2, getting about 20 years. Given time, the drugs are going to be less and less effective. Problem is, this is a smorgasbord of pills. None of these pills are cheap. And I'm not going to go into discussing of pharmaceutical companies and how evil they are and things like that. When it's a drug that only 1 million people in the world are going to want, they're not going to be making a lot of money out of it if they kept it cheap. And it took billions and billions of dollars to develop it, so whatever. If you think it's too cheap, you think they should be giving it away, well, you know what? Start your own pharmaceutical company. Start making your own. So HAART is really good here in the Western world, not so good in third world countries. South America, Africa, Southeast Asia. So they are trying to develop their own drugs, their own methods for treatment of HIV. Unfortunately, there are some countries where basically they're just doing to HIV patients what historically they did to lepers, people with Hansen's disease. Ostracize, let them figure it out themselves because they're going to be dead in a few years anyways. AZT is one of our antiretroviral targets, the reverse transcriptase. This thymine kind of sort of looks like, but is not really, the DNA nucleotide thymine. This right there screws stuff up. So not every T in the DNA that's being made will have this as azidothymidine. Maybe 1 out of 100, 1 out of 1,000, maybe 1 in 1,000,000. Don't know. But it's enough that this will shut down things. So you'll get, instead of the complete DNA chain, thanks to RNA-dependent DNA polymerase, it'll go abort, abort, new one, abort, start a new one, abort, start another one, abort. Will it abort, stop all? No, but enough that it can start kicking down what's being made. And you keep doing it. You keep taking these AZTs and all the others at the same time. This one right here, nevaraprin, where this is screwing up the activity of. This is screwing up the ability, just the function of the reverse transcriptase. This gets into the active site. This screws with the shape. There's no effective vaccine, okay? And like I mentioned a few minutes ago with the US versus Europe, that opens up a whole different kettle of fish. Basically, right now, our best thing is education. As I mentioned in a previous lecture for this chapter, for some reason, there are people who seem to think that because people are living longer, we have cured AIDS. HIV infection, we've cured AIDS. You know, they're not getting AIDS now, we've cured it. No, we haven't. We've learned more. We've got better antiviral drugs, but still, instead of 5 to 7 years, it's now 10 to 20. But they're still getting AIDS. They're still dying. Well, we got to keep hammering away at it. Unfortunately, HIV rates are on the uptick because, well, people are stupid.